talk about Alzheimer's disease, vascular dementia, and mixed dementia. So as a federal employee, nothing I say represents any of those federal institutions, and I have no financial conflicts of interest for this talk. So I always try to start with a common language because, and some of this may be rudimentary for some folks, or it may be information and language that is really important to hear. And part of that is because the most common question that I get asked in clinic is, well, okay, so what's the difference between Alzheimer's disease and dementia? That's easily the most common thing that I answer. And so I think starting with how someone like me is using those terms and what they mean is an important place to start. Then we're going to talk about treatments for Alzheimer's disease, vascular dementia, and mixed dementia, and sort of what we mean by that and whether that matters. So first, this is just a graph to describe neurodegenerative causes of dementia. And so if we start with normal aging, these are things that all occur in everyone as we get older. Processing speed gets slower. Other things sort of continue to get better as we get older. So-called sort of crystallized intelligence usually increases, and fluid intelligence, or being able to sort of rapidly process things, might start to get worse. That's normal. When there is any decline based on where someone is in their age with education level, there's a decline below what we expect to be normal aging. Someone has a concern or a complaint. That can be a loved one, that can be the person themselves, or that can be a physician who's known them. There's got to be a concern, low scores on the tests that we use. But importantly, there's no real decline in daily activities. There can be, there can be differences in the quality of how they do it. They may need a little bit more assistance for some things, but essentially they're functionally doing okay. That's what we call mild cognitive impairment. And to be clear, mild cognitive impairment tells you nothing about the cause. The cause can be prodromal Alzheimer's disease, or it could be, say, untreated sleep apnea or some of the medications that people are on. And that's why in mild cognitive impairment, we tend to see a small number of people who actually will get better. We see some people who kind of stay the same and they don't necessarily have a decline over the years. But then in some individuals, MCI is a pre-dementia state. And almost by definition, anyone who has Alzheimer's disease, Lewy body dementia, and the like will go through MCI before they reach a stage of dementia. That it may not come to clinical attention, but because if there's no functional impairment, sometimes people don't seek out evaluation. At the point that there is impairment in those daily functional activities, that's what dementia means. And dementia, again, doesn't tell you what's causing it. You could have dementia due to strokes, Alzheimer's disease, a traumatic brain injury, past alcohol use. So dementia is kind of what I tell people in clinic is that, MCI and dementia is kind of like saying your arm's a little weak or your arm is paralyzed. It doesn't tell you why those things exist. It just describes the symptoms that someone has. So staging the severity of dementia, there's more complicated ways to do this, but I think some of them are less helpful. So I usually just think about it in terms of mild, moderate, and severe. And so mild dementia means that there's impairments in these things that are required for independent living: driving, cooking, cleaning, finances. Moderate dementia is when there are impairments in meeting one's physical needs, getting dressed, personal hygiene, feeding oneself, things like that. And then finally, severe dementia is when someone is truly fully dependent on others for their day-to-day needs. If we're going to talk about treatment effects and what treatments do and mean, we should sort of talk about broad categories of what we can expect from treatments. And these first ones that I'm going to show you are things that we don't really have. Okay, so first, there's just no effect, right? If I all the evidence I have is that if I give you ginkgo biloba, it doesn't make any difference. It has no measurable effect in trials on patients with cognitive decline. The same thing is true for some of the supplements that you see on TV. Nareva, Prevagen, they have no discernible effect when they've been studied. Doesn't mean that people don't feel like there's an effect when they take them, but from a trials perspective, there's no real data that it changes anything. There's also something, we might find something that could slow the progression of a disease like Alzheimer's disease. We don't really have that. There's nothing that we've found that convincingly slows the progression. The holy grail would be arresting the progression or even reversing, but we don't have anything that does that. So what we do have is what I would refer to as a symptomatic benefit. And so these are palliative treatments. They are intended to treat a symptom. They are intended to lead to some measurable benefit in cognition. And this is a good example of this is Aricept. So Aricept or donepezil or the drugs like that, they do not protect against future decline, nor do they change the slope of the decline. So you can see here that the blue line is the same slope as the red line, but there was some improvement, right? So the symptoms may get better for someone, but if the disease is Alzheimer's disease, and I always tell people this really explicitly because otherwise we end up in this situation where, so this is, this would be sort of, when we talk about prolonging functional independence, whatever that line is there is how long we've prolonged functional independence. But if somebody comes in 3 years later and they're down here, they'll say, well, it didn't work. Well, but it did work. It just didn't do what we wanted it to do, but we can't expect it to do that. And so if I don't explain this to folks, then I'm setting them up to really misunderstand what we can reasonably hope for with the treatments. Now, the sort of straight downward line that we're seeing here tends to describe things like Alzheimer's disease that are by definition neurodegenerative. If somebody has, say, a post-stroke cognitive impairment, we have less, and I'll talk about this in a few slides, we have less evidence for things like Aricept or memantine in those cases, but the line of that disease may be more sort of stable. And so if somebody has a stable illness that's not going to get worse over time, if we get that symptomatic benefit, it'll sort of stay up higher. So I didn't draw that out, but you can imagine if you had a flat line and you got a benefit, you're going to stay on that flat line. So it really depends on the underlying disease as to what we might hope or expect for an individual. But this is sort of the typical graph that I draw out for people when we're talking about what does Aricept potentially get you? What might memantine potentially get you? Now, we're going to talk about Alzheimer's disease and vascular dementia today. These are by far the most common clinical diagnoses that we make in clinic. And they represent quite a number of cases of later life cognitive decline. And even one of the statistics that we learn in medical school is, well, before the age of 65, frontotemporal dementia is much more common. And that's true, but it's still the second most common after early onset Alzheimer's disease. Early onset Alzheimer's disease is still the most common cause of dementia before the age of 65. Now, the reality, though, is that, on the left-hand side here, you see these nice, neat categories. So, well, this person has Alzheimer's disease. This person has vascular dementia. This person has Lewy body dementia. But the reality of what's happening in the brain is nowhere near that neat. And so certainly people exist who may only have Alzheimer's disease pathology in their brain, but about 50% of people actually have comorbid Lewy body disease in the brain. And the same is true of people who have clinically Lewy body dementia. Well, it turns out that 50% of them also have amyloid and tau in the brain. Vascular dementia is incredibly common to be comorbid with Alzheimer's disease. And so this is messy and this is hard to explain. One of the ways that we know this is from autopsy studies. And I'll show you an example of that with a graph in the next slide. But we do, as one of the studies that we have at Wake Forest is our brain donation study. So we have people who either are part of our ongoing research studies or just people in the community who their family wants a final diagnosis, or the person in their life had wanted to contribute their body after their death to research, and so they will donate their brains after they die, and we give them a pathological diagnosis. And that pathological diagnosis is never just one line. It's almost never a single line. It usually looks something like, well, there were really high levels of Alzheimer's disease, but we also saw moderate levels of vascular disease in the brain. Or, yes, there were the highest levels were of Lewy body dementia, but they also had sort of moderate Alzheimer's disease and vascular disease. So even though we make a categorization clinically of what someone's illness sort of looks like, what it best fits with the symptoms, the reality in the brain is often much more complicated than that. And as an example, so this is a paper from 2007 from the Rush group in Chicago, and they've done a tremendous amount of this work. And so you can see here, so this is just a graph of people who had, so these are folks who just lived in the community, who both had and did not have dementia. So of all the cases that went through autopsy, mixed dementia is by far the most common. Alzheimer's disease was second, brain infarctions were third, and then Lewy body disease was fourth. But mixed here is much more common. And so if somebody had both Lewy body disease and Alzheimer's disease, they wouldn't show up in these columns. They're going to show up over here in the mixed column. And then down here, these are people without dementia. And so you can see here, certainly, 35% or so of people had no major pathology in the brain, but 30% of people who did not have dementia, who died and donated their brain, had Alzheimer's disease present. 20% of them had infarctions and strokes, and another 10% had Lewy body disease, and then many had mixed pathology. So what this is sort of telling us two things. This is telling us that, one, the pathology in your brain is not the same thing as your clinical presentation. Lots of people who are cognitively normal have these pathologies in their brain. And we see this all the time in our Alzheimer's Center. We have half of our group, 300 or more people are all cognitively normal. They go through an extensive evaluation and they are cognitively normal for their age. But when we do PET scans to look for the presence of amyloid protein, we find, a decent percent of them have the presence of amyloid, so a marker of Alzheimer's neuropathologic change, but they are in fact normal. And that's because we now know that Alzheimer's disease begins 20 years before any symptoms are present. And amyloid alone is not enough to cause the clinical syndrome of an Alzheimer's disease dementia. So part of the point of this slide is to kind of, the first step is recognizing that dementia isn't really a diagnosis, it's a description, and that there are these multiple categorizations of dementia. But the even deeper level of understanding is realizing that all of those categorizations are themselves a little bit superficial, and that the reality is many cases, and in fact most cases, have at least some degree of mixed pathology. So I may diagnose somebody with dementia with Lewy bodies, and they fit the criteria and they meet it perfectly and they respond to the treatments like I expect them to. But when we look in their brain, they may both have Lewy body disease and Alzheimer's disease. And so to kind of make that point just one more time, when I make a diagnosis, and this is not the same that you'll see with every neurologist, this is very specific to someone who is a subspecialist in behavioral neurology who really only deals with dementia clinically. The first thing that I do is figure out, is there something wrong? I have lots of people who come in to see me who appreciate changes in their memory, and they do not have a diagnosis of MCI or dementia at that time. And it's about 25% of people who come into a memory clinic do not have a primary memory disorder. So the first step that I've got to have is there an identifiable decline? And if there is, I need to describe it. Is it mostly a memory problem? Is it an executive function problem? Is it a language problem? What is it? What does it look like? And so, somebody who has early Alzheimer's disease, they ought to look different for a clinical diagnosis than somebody who comes in with very early Lewy body disease. And so from there, I sort of put together, how is there a problem and how bad is it? So mild cognitive impairment or dementia. And then I describe it. Is this mostly memory? Is it mostly language, et cetera? And then, and this is the step that I think a lot of times people don't take, is what do we think is causing it? Recognizing that it's not perfect. I just showed you the mixed dementia, so I may not be fully correct when I make a determination of what I think the likely cause is. But it's important to think through this because, and I'll describe this when I talk about Aricept. One of the things that I know Pat will tell you, if you've been in any of the LBD support groups, Aricept can have a really tremendous response for a period of time in Lewy body disease. It can be very important. And if I think that somebody has Alzheimer's disease, but then they also show some, maybe they have what looks like Alzheimer's disease, but they also act out their dreams a little bit and they're starting to hallucinate, I will at least consider in my note that what we may be seeing is Alzheimer's disease and Lewy body disease, because I know that mixed pathology is fairly common, and that may influence how much I would recommend starting Aricept, how much I would try to really push that dose and get it higher. Now, I'm not going to talk about, well, no, one second. Okay, so all of our treatments really are palliative at this point. Palliative means we're targeting symptoms to improve quality of life. So what I tell all of my patients is, look, if I give you something and your life is not better, we should just stop it. It's really that simple. Nothing I give you has value intrinsically of being on it. So it's not like high blood pressure, right? High blood pressure, you don't experience a benefit from that medication in your day-to-day life most of the time. You're taking it on the belief and the understanding that lowering your blood pressure lowers your risk of stroke, heart attack, and that's a good thing. None of the medicines that I prescribe people with dementia, with an exception for vascular dementia, which I'll talk about in a second, change the course of that illness. So Alzheimer's disease, we can't change the course of the illness, we can treat the symptoms. Some of you may have questions about aducanumab. I'm going to put a star by this, and I'm happy to talk about this after we go through the slides. The short version is the evidence of benefit is profoundly lacking. There is evidence for potential harm. It's really not covered by any insurance at this point. And I personally would not prescribe it for my family. I don't think that it has compelling evidence that it does anything, and I don't think brain bleeds are harmless. So we can talk more about aducanumab, but to the best of my knowledge, no major institution in the state of North Carolina is prescribing it on the formulary. You would have to go out of pocket, and it's at least $28,000 a year, and it is not worth that, in my opinion. So for cognitive symptoms, right? So acetylcholinesterase inhibitors are FDA approved for Alzheimer's disease. They have a modest benefit. It varies across people. I forgot to put best case scenario here, but what I should have written was sort of best case scenario that we're looking at in Alzheimer's disease is prolonging functional independence by 6 months to a year. That's sort of what you hope for with Aricept. But if it is Alzheimer's disease, by definition, the symptoms will progress, and Aricept cannot stop that. We do know, however, that there was a very nice trial done in the UK where they said, people will, it's not uncommon for people to say, well, this person has severe dementia, we should just stop those drugs. And so there was a trial called the Domino trial that showed, well, actually, when you stop them, even in severe dementia, it can lead to a decline in neuropsychiatric symptoms. So people may have more agitation, they may, experience worsened symptoms. So I generally don't stop them unless there are side effects or unless we are really at, end of life, hospice type care, because I think there is still a small benefit. Side effects, it can slow heart rate. So sometimes you do need to do an EKG first. Stomach upset is probably the most common thing. There's ways around it. You can go, we normally do 5 milligrams for a month and then 10 milligrams. Sometimes I'll go really, really slow, like 2.5 for a month or 2, 5 for a month or 2. And the stomach upset, you can get around it that way, but it takes much longer to get up to the higher dose. Can also cause some increased urination, salivation, runny nose. The evidence is mixed for vascular dementia, but I do usually discuss an empiric trial. There's some studies that suggest maybe you get a cognitive benefit, others that really don't show much of a benefit. But just like in Lewy body disease and Alzheimer's disease, truly pure vascular dementia is often pretty rare. There are certainly younger folks who have strokes in strategic areas and it's purely vascular, but it's not uncommon for vascular dementia to be present and Alzheimer's disease to be present. So I think it's usually worth an empiric trial as long as people fit, don't have contraindications. But I also told you that Lewy body disease is roughly about 50% comorbid with Alzheimer's disease. And so, there may be reasons to consider, when I have a diagnosis in mind, it's not like this immutable thing, right? So it's the best explanation that I have at the time to explain all of the data that's in front of me. But if I have a patient with Alzheimer's disease who maybe starts to show some features of Lewy body dementia, I will consider, treating along the lines of what I would usually do in Lewy body dementia. And that can be really relevant because in some cases, the cholinesterase inhibitors can help with the psychosis and the hallucinations. And those are really hard to treat. And the antipsychotics have side effects that are not pleasant. And so, it may be a reason for me to consider, yes, I still think this is Alzheimer's disease, but these other symptoms could also suggest underlying Lewy body disease. It's sometimes difficult to go into all of this in the course of a clinical visit because it's complicated. I end up, I'm sort of telling you that the diagnosis isn't as firm as you would like it to be. I have to constantly reconsider, is there another thing going on? And that's its reality, but it is, it's unsettling that we don't have these firm, perfect, clear diagnoses. Memantine or Namenda is really only FDA approved. It's only FDA approved for moderate to severe Alzheimer's disease. Evidence isn't great for its benefit. There's ongoing trials in things outside of Alzheimer's disease, but it's usually really well tolerated. It causes some stomach upset. It can make people more confused and sleepy. There's really no great data in vascular disease, but again, we may try it empirically because it is a fairly safe medicine to try. And in LBD, there's some small trials and there's an ongoing trial. So I usually will consider an empiric trial in patients of this medicine. And if it's really a primary frontotemporal dementia, there's no evidence that memantine helps. It's been studied really well. So in that case, there's not this conflicting evidence. There's really pretty good evidence that it doesn't help. And FTD tends to be a little more isolated in the pathology. So I see less FTD with comorbid Alzheimer's disease. And that's because people tend to be younger. Now, what will I do if somebody comes in and I think they have FTD and somebody started memantine and they say, well, it really helped? I mean, I'm not going to stop it. I don't see any reason to do that. It's just not something that I typically start. I think there are better solutions to most of the symptoms in FTD. Now, vascular dementia deserves kind of a separate discussion because of all of the causes of dementia, the only thing I told you earlier, there's really no such thing as a disease modifying treatment. And that's true for medicines, but the best evidence we have is that treatment of blood pressure does help reduce the risk of progression from mild cognitive impairment to dementia. So treating vascular risk factors is probably the best thing we have for maybe modifying that trajectory. So, if getting high blood pressure treated, if it's present, is important. If somebody's had a stroke, it's called risk stratification, meaning that we look at each risk factor and we try to do what we can to reduce that risk factor in accordance with evidence. So we will start aspirin or Plavix or both for a shorter period of time immediately after a stroke because it reduces the risk of an additional stroke. It won't fix the cognitive changes that are present, but if one has cognitive impairment, an additional stroke will only hurt. So it's worth trying to reduce the risk of another stroke. If somebody has atrial fibrillation, we may recommend anticoagulation, which comes with its own host of potential concerns and problems, and not everybody is right to be on that, but that's a sort of a more, it thins the blood more, it makes the blood less likely to clot even than aspirin. Somebody has diabetes, we may focus on making sure that that's under good control. Smoking, one of the biggest risk factors that we have for stroke. So working on people stopping smoking. So if a current intervention is course modifying, disease modifying, it is absolutely prevention of stroke and vascular brain injury in individuals who are at risk for and have that. So that's sort of the one that I think I have the best chance of helping to modify the likelihood of future impairment. The next thing to talk about are neuropsychiatric symptoms, because of all the things that I see and treat, these are the ones that I usually spend the most time on. There's not much I can do as a physician for cognition. I have 2 classes of drugs. We can get folks on them pretty easily, but if those don't do much, there's not much else I can do to modify memory. So when people come in and they say, I want them to remember something, we have to have the conversation that I really, really wish we could do that, but it's unlikely that what I have is going to directly change that beyond the often modest benefit of these 2 drugs. Neuropsychiatric symptoms, because of my practice and what I tend to see more of, are the things that I spend the most time actively attempting to manage. And so, going through what we can do for that, first we got to figure out, does it need to be treated? If it's distressing, if it's mildly distressing to someone's caregiver, but it's not harmful, it's not frequent, they can be redirected, we probably shouldn't give a medicine for that right then. We should talk about that behavior, talk about ways to navigate it, get around it, but we may not want to treat it. Some things are less likely to be treated by medicine. So if somebody's verbally aggressive, I sort of look at things that might be responsive and might not be. And if somebody's in pain or has psychosis, or if they're depressed, that may benefit. If somebody has, if they're bored, if they're experiencing overstimulation, I'm not going to fix that with medicines. And so then we have to talk about how do we maybe address those things in the environment to help reduce that neuropsychiatric symptom. So I'm not sure. Let me see. Okay. I'm not sure where those, I don't know if you guys can see those lines on there. I'm not sure where they're coming from, but I'm just going to keep going with them. They don't really obscure anything. So first thing with these symptoms is we have to assess safety and consider physical changes. Infection, pain, discomfort, constipation, poor sleep, all of these can trigger fairly sudden onset of neuropsychiatric symptoms. I consider whether new medications have been started. And this is kind of a worst offender list of things that I see that could be causing a delirium in somebody with cognitive impairment. So, Benadryl, NyQuil, anything with PM on it is bad because it's an anticholinergic medication. And so trazodone for sleep, Claritin for allergies, a little bit better tolerated. Benzodiazepines often have problems. We try to minimize their use. Oxybutylene, urinary incontinence, is so common, and this drug in particular has a lot of anticholinergic side effects and can worsen confusion. I can't tell you the number of people that I see who are taking Antivert or Meclizine for intermittent vertigo, but they're taking it like daily, not intermittently, and that could be worsening their confusion. Some of the antidepressants like Paxil are bad ideas in older adults. Muscle relaxers and things for stomach cramps can also cause confusion. And so we try to, modify that and do things that are better options as we can. So trying to minimize things that may harm, maximize things that may help with those symptoms. The different classes of drugs that we use, antidepressants, these are things like Zoloft, citalopram. We use that for mild agitation. Agitation is usually sort of purposeless motor activity, can't sit still, seem very sort of like amped up, can overlap a bit with aggression. Depressed mood, anxiety, apathy with the more activating drugs like Effexor and Wellbutrin. So that's kind of what we tend to use those medicines for. Antipsychotics, we tend to use this for people that are experiencing frank psychosis. Sometimes with more difficult to treat aggression, we have to resort to these. In folks, and if the agitation's really resistant or the anxiety is really resistant, we may resort to these in a palliative sense. So we're just trying to help alleviate the suffering and the distress caused by those symptoms. Now, all of the antipsychotics have a black box warning for increased risk of cardiovascular events and death. And I talk to all of my patients about that because it is a palliative decision to use these medications. And people have to understand that there is a risk associated with them, but we often don't have better options for trying to alleviate some of those really distressing symptoms. Now, the note on here is that Lewy body dementia is particularly sensitive to antipsychotics. And so really, I tend to use only quetiapine in those folks. And in Parkinson's disease dementia with psychosis, I will occasionally use the newer drug pimavanserin or Nuplazid. Cholinesterase inhibitors, the Aricept that we talked about. So I use it a lot in Lewy body dementia. It's my first line for most symptoms in Lewy body dementia, and I don't use it at all in FTD because it can make things worse in FTD. For depression, it can maybe help augment depressed mood if used with an SSRI. And finally, it's the first line for apathy because it's the safest medicine for apathy. There was a new trial that came out last year that showed that fairly low dose Ritalin or methylphenidate, a stimulant, did help improve apathy in Alzheimer's disease. Problem is, it's also associated with an increased risk of cardiovascular events in the first 30 days of its use. So it's again, if it's really bad apathy and it's causing a lot of distress and difficulty with care, it may be appropriate to try that, but in full light of what the potential risks are. For sleep, I almost always will use trazodone or mirtazapine if we have to use something. I'll try melatonin first. It can be a little effective for insomnia. Some people, it really does seem to do the trick. And it's probably first line in acting out dreams and with Lewy body dementia and related conditions. Memantine or Namenda, again, it's a cognitive treatment, but it seems to maybe help reduce these neuropsychiatric symptoms at sort of a global level, and it's safer than a lot of other things. So potentially getting folks on a dose of this may help me use less antipsychotic. That's the rationale for trying it. But I should also say, if it's really bad agitation and aggression, memantine is not going to do the trick in most cases. And so it sort of depends on the severity. Benzodiazepines are usually no-nos. We don't like to use them. There are exceptions to every rule. Really severe panic and anxiety or in behavior disorder, short doses for insomnia may be appropriate. And then stimulants. So again, sometimes for depression with an SSRI, if there's comorbid apathy, for just frank apathy without the mood disturbance, they can be effective. And then for Lewy body dementia, just to have a mention on here that with really severe daytime somnolence with no other cause, sometimes that can be helpful. So that is the end of what I have. And these are just some pictures of my lovely children.